We all respect blood pressure nowadays. We all smack any of our patients who are smoking and tell them to stop smoking. And why wouldn't you therefore jump in early in the game with high ApoB, high LDL cholesterol and start lowering it? What are you waiting for? This is an asymptomatic disease until you wind up in the graveyard or the coronary care unit.
Dr. Thomas Dayspring is a professor in internal medicine and in lipidology and world-leading expert in lipidology. He's been a founding member of the National Lipid Association. He won multiple awards, including the 2011 NLA President's Service Award and recently in 2023, the Clinician Educator Award. Dr. Dayspring, it's a huge honor to be sitting with you today, and thank you very much for accepting my invitation. And I would like
it's
to
a great
ask
honor to be asked.
Thank you very much. And my first question is about LDL cholesterol. There is a lot of confusion about LDL cholesterol. We hear often large buoyant LDL, small dense LDL. There is also oxidized LDL, remnant LDL, LP little a. Which of these are atherogenic, and do we have to know the difference clinically?
Yes. Atherogenesis, of course, is the deposition of cholesterol in the artery wall, and over time, these complex plaques form that can either obstruct the artery or rupture, cause a clot that occludes the artery. And the big question is, how does cholesterol get into the artery wall? Cholesterol, being a lipid, is a hydrophobic molecule that cannot circulate in plasma unless it's in a protein-enwrapped vehicle called the lipoprotein. There are two classes of lipoproteins, those whose structural protein is called apolipoprotein B, and there's one ApoB peptide per ApoB particle. The other particles in our blood are our high-density lipoproteins, and their structural protein is apoprotein A1, capital A1. So your question deals with the LDLs. So in the ApoB family, there are three groups of particles which are separated by their buoyancy in a centrifuge. So those that float on top are called very low density. Those that sink further in the tube are lower density. And in between VLDLs and LDLs is a particle called intermediate density lipoprotein. There are very few of them, so they're not usually factored into much of what we do. So now, of the VLDLs and LDLs, here's the key point. There is a metric called plasma residence time. Once any of these lipoproteins are secreted into the plasma, how long do they stay there before they're cleared and they're gone? So VLDLs produced in the liver are secreted, and they are catabolized within 3 to 4 hours and they're gone. So they have a very short half-life or plasma residence time. Whereas the LDL particles, once they're secreted into the plasma or they form from a VLDL, they hang around for 2, 3, upwards of 5 days in some cases. So the plasma residence time is much, much longer for LDLs than VLDLs. Now, there is one ApoB on every VLDL and every LDL. So total ApoB would be VLDL particle count plus LDL particle count. But because of the very long half-life, 95% of our ApoB particles are LDLs. And the importance is it's the ApoB particles that can leave plasma and carry cholesterol into the artery wall. And the factor that determines whether an ApoB particle, the vast majority of which are LDLs, leaves plasma or is cleared by the liver is particle number. Once you exceed a certain threshold of LDL particles, they will, by a gradient, just enter the artery wall and over many, many years cause atherosclerotic plaque to develop. Doesn't happen overnight. It's a very slow process, atherogenesis. So the crucial parameter that clinicians need to know is really LDL particle count or ApoB. They're pretty much measuring the same thing. Now, most clinicians around the world, even in the United States, are not ordering ApoB. Many are unfamiliar with this concept, and not every lab in every place offers ApoB. So what we have to do is guess what the ApoB level is. And using the standard lipid profile, there are two metrics in the lipid profile that tell us probably the ApoB, the LDL particle concentration, is at a potentially dangerous level. And the first would be what everybody's looking at, LDL cholesterol. Now, LDL cholesterol is simply the mass of cholesterol molecules that is in all of the LDLs per deciliter of plasma. In the United States, it's measured in milligrams per deciliter. So they're basically taking the LDLs in a deciliter, 100 cc's of plasma, and they're weighing the cholesterol molecules in them. So that's where, hey, ideally would be less than 70 milligrams per deciliter. Of course, in virtually every other part of the world, they use molar concentrations. And what that is they're taking all of the LDLs out of a liter of plasma and they're counting the number of cholesterol molecules in molar concentration. They correlate incredibly well with one another, and you can calculate milligrams to molars and vice versa if you are doing that, or you get a report that you don't understand the metrics with. So LDL cholesterol has a pretty high correlation with LDL particle count, or ApoB. So in general, when we see LDL cholesterol going up, we say, uh-oh, this person has likely too many ApoB particles. And remember, any LDL that exists above the physiologic threshold is potentially atherogenic because it can enter the artery wall. If you have low levels of LDL particles, that just means your liver LDL receptors are clearing them very efficiently, and you don't have the numbers needed to penetrate the artery wall. That's called LDL clearance, performed by LDL receptors in the liver. So LDL cholesterol, I call it the poor man's ApoB guesstimate or surrogate. The problem is, although there is high correlation between LDL cholesterol and ApoB, there are people where they don't correlate well. You could have high LDL cholesterol and normal ApoB, and therefore don't have any risk, even though your LDL cholesterol is high. Or you could have high ApoB and a pretty good looking LDL cholesterol, in which case you are at risk despite your low LDL cholesterol. That is called discordance, when the two metrics do not agree with one another. That is typically seen in situations where triglycerides are elevated. And of course, the most common cause of elevated triglycerides, even globally nowadays, is insulin resistance. Trigs go up. The LDLs, instead of carrying cholesterol, which is their mission, they start carrying extra triglycerides, which means they carry less cholesterol. So LDL particle count could be high, but because the particles are cholesterol depleted, your LDL cholesterol looks good. The better metric in the lipid profile to correlate with ApoB is something called non-HDL cholesterol. And that is a free calculation. You take the total cholesterol, that's the cholesterol in every lipoprotein in your body, and you subtract from it the HDL particles, because they're typically not atherogenic particles. So if you subtract HDL particles from total particles, you have ApoB particles left. So ApoB cholesterol is called your non-HDL cholesterol. It's the cholesterol that is not in your HDL particles. And if cholesterol is not in an HDL, it has to be in an ApoB particle, 95% of which are LDL particles. So non-HDL cholesterol actually has a higher correlation with ApoB than does LDL cholesterol. So for clinicians who can't, for whatever reason, get apolipoprotein B, I recommend they pay much more attention to non-HDL cholesterol than they do LDL cholesterol. And it's a free calculation, so it's not like it's an extra lab test you have to order. So that's what LDL cholesterol is. It's a guesstimate of atherogenic particle number. ApoB, or LDL particle counts using other technologies, is the most direct assay to do that. LDL-C and non-HDL-C are guesstimates. You did mention something called lipoprotein little a. Now, the LDL family, like all lipoprotein families, are actually heterogeneous groups of variously sized particles. So even the LDLs, you can have big LDLs, intermediate size LDLs, and small LDLs. They're all LDLs because they have the buoyancy where they would go in the LDL range in a centrifuge. But the bigger LDLs float a little higher than the smaller, denser LDL particles. But they're all LDL particles. They all have one ApoB. An LDL-ApoB or an LDL particle count is the sum of big LDLs, intermediate LDLs, and small LDLs. What really matters with LDLs is total LDL particle count, or ApoB. But there's a lot of talk out there, oh, the big LDLs are not so dangerous and the small LDLs are worse. That needs some maybe, maybe not. I laugh for people who say that. One of the more lethal lipid disorders that we have is familial hypercholesterolemia. They have incredibly high LDL cholesterols, defined as typically in an adult above 190 milligrams per deciliter. So they all have big, fluffy, buffy, buoyant LDL particles, and they sure get a lot of atherosclerosis. So that shoots down the theory that big LDLs are not atherogenic. Now, the small LDLs are an LDL particle. And the problem is in people who develop small LDLs, and that's virtually everybody who has elevated triglycerides, that's where this type of LDL is seen with prominence. And that's because when trigs go up, trigs go in the LDL, and lipases dissolve the triglycerides, which shrinks the LDL particle. So it's triglycerides that make the LDL particle small. Now, here's the problem. A few minutes ago, I alluded to something called hepatic clearance of LDL particles. The liver expresses a receptor called an LDL receptor, which is specifically engineered to bind to and recognize the ApoB on an LDL particle. So the LDL receptor grabs the particle and pulls it into the liver where it's catabolized, and it obviously cannot hurt you in the liver, causing atherosclerosis. The problem is the LDL receptor only recognizes ApoB when it's on an intermediate particle and it has a certain conformation that aligns to the electrical charges on the LDL receptor. So if you have a small LDL, the ApoB assumes a different shape. And the LDL receptor doesn't recognize it as readily as it would. So small LDLs have decreased clearance from plasma. And that's why most people with small LDLs have increased LDL particle counts, because the small LDLs cannot be cleared. And remember, what drives atherosclerosis is LDL particle number, not the size of the particle. But au contraire, just the opposite. If you have a really big LDL, such as an FH, the ApoB also assumes an abnormal conformation, and the LDL receptor doesn't recognize that LDL as readily either. And that's part of the contribution to the high ApoB in people with familial hypercholesterolemia. So people should not dwell on small or big particles. What we should dwell on is total LDL particle count, which is guesstimated by LDL cholesterol, much better by non-HDL cholesterol, or measure ApoB. If you take the people which, for some reason you've measured that, oh, they have small LDLs, the next thing you should do is a total LDL particle counter in ApoB, or look more closely at non-HDL cholesterol, and you would see, my God, no wonder the small LDLs are so dangerous. They're driving particle number through the roof. So that's the where this small and big comes in. I think all the studies have shown if you have too many big LDLs, you're at risk for atherosclerosis. If you have too many small LDLs, you're at risk for atherosclerosis. But I will say this, the small LDLs, as I indicated, are caused by triglycerides. In other words, they occur in insulin-resistant people where there's a lot of metabolic abnormalities going around. So people with small LDLs not only have too many LDL particle counts, they have inflammation, they have glucose abnormalities. So they have multiple things which put them at even higher risk for atherogenesis. So it's not all the small LDL, it's who else does the small LDL hang around with in your plasma? And it's a lot of bad actors there. I'll finish up the LDL discussion with this LP little a that you mentioned. So,
Yes.
yes, LDLs come in big, intermediate, and small sizes, but there's another member of the LDL family that occurs in, well, it occurs in everybody, but if it goes above a certain concentration, it's a bad news LDL particle. So all it is, remember, an LDL particle is a collection of cholesterol, a little bit of triglycerides, some phospholipids on the surface, and one ApoB peptide, which is the structural protein enwrapping the lipids. In some people who inherit a gene, LPA, in italics, the LPA gene, uh, their liver starts overproducing too much of apoprotein little a, not capital A. That's an apo capital A is on an HDL particle. Apoprotein little a, small case a. So if your liver makes increased concentrations of apoprotein little a, once the liver makes it, the liver is also making what we call primordial baby LDL particles that they're getting ready to secrete. So what happens within the liver cytosol is apoprotein little a attaches to some of the LDLs that the liver is making. And then you have an LDL particle that is glued to apoprotein little a. Hence, that's called the lipoprotein little a particle, LP little a particle. And the liver secretes it. And just like LDLs, everything relates to the concentration. If you have trivial levels of LP little a in your plasma, that's defined if you're using molar concentrations as less than 50 nanomoles per liter, you're at no risk, even though you have a minute number of LP little a particles floating. And it's a rare person who has zero LP little a. Most humans have less than 50 nanomoles per liter, but 1 out of 5 have actually elevated LP little a levels. And the higher the LP little a level, the higher the danger for atherogenesis. That apoprotein little a has several pro-atherogenic properties. Now, too many LDLs are bad news. If now you stick on a protein that is also potentially atherogenic, you have a very, very potentially lethal LDL particle. LP little a is by far the most frequent genetic lipoprotein abnormality that results in atherosclerosis. It's way more common than the familial hypercholesterolemia that I was talking about. That's probably 1 in every 250 people. Certain countries have a little more. But LP little a in general is 1 out of 5 people. But in certain ethnicities or races, it's 1 out of 3 or even 1 out of 2. Women have higher LP little a concentrations than men. So the guidelines are now recommending, because this is so lethal, and if you don't measure it, you don't know you have it until you get a heart attack or a stroke, that everybody, once adulthood is reached, should have an LP little a test, because it would factor into when we do cardiovascular risk assessments. If I have 2 people, one has high LP little a and one does not, obviously the person with the high LP little a is at much higher risk than the person who doesn't, regardless of what their other lipids show. Now, they can compound the LP little a, but even if you have decent looking lipids and your LP little a particle concentration is elevated, you're at increased risk. So we all should be checking that in all our patients. Right now, once in your life, you really don't have to repeat it. There are potential drugs in development that may stop the liver from making LP little a particles. They're still undergoing clinical trials. If they work, I think in those people, if we prescribe those drugs, you will repeat LP little a after you administer the drug. But right now, there's no, even though we have one drug that can lower LP little a little bit, doesn't lower it a lot. So maybe you could repeat LP little a if you go on what's called a PCSK9 inhibitor, which has the ability to lower LP little a little bit. And doctors are starting to widely use that until the newer drugs come along. So if I put you on a PCSK9 inhibitor, I would repeat your LP little a to see is it doing anything or not. But if you're not, if you're on any other lipid drug, statins, ezetimibe, bempedoic acid, they do nothing to LP little a. So there's no sense repeating LP little a when you're using those therapies because it won't give you any information. Well, you did mention oxidized LDL. Look, part of the reason LDLs cause atherogenesis is once they invade the artery wall, they're subject to reactive oxygen species, which start oxidizing the phospholipids on their surface. And an oxidized trapped LDL, it's like a pro-inflammatory LDL. So the macrophages that are in your artery wall, they start gulping oxidized LDL particles. So oxidation within the artery wall contributes to atherogenesis. Measuring ox LDL in the bloodstream is a total waste of money. It has nothing to do with anything. If you measure ox LDL and you say, oh, it's high, but if you would then measure ApoB and adjust it for the ox-LDL factors away as not being important. So yes, ox-LDLs are very important, but that occurs in the artery wall, and we cannot measure arterial wall oxidized LDL particles at this time. So that's the ox-LDL story. So that was a long answer to your what I call a difficult question because it has
No,
so many aspects to
thank
it.
you very much. That was the most incredible recap of lipidology I have ever heard. So that was very, very informative, and I have so many follow-up questions. Uh,
Go.
so, if for people who have borderline high LDL, so between let's say 130 and 189, should they test for familial hypercholesterolemia, or should they do any genetic testing?
It's not really needed. And you can make the case that even if you have an LDL cholesterol of 190 or above, so you certainly have genetic hyperlipidemia. There's a couple of secondary causes that could drive your LDL-C that high. In the old days, it used to be hypothyroidism. We never see that magnitude of hypothyroidism to make your LDL-C 190 anymore, at least not in a developed country. Kidney disease, certain liver diseases can send your LDL cholesterol through the. So you have to rule those out once you get a high LDL cholesterol of any magnitude. And most of the time, they're pretty easy to rule out. You do liver tests and those type of kidney tests to look for that. So if you have a high LDL cholesterol, extremely high, or in the intermediate zone that you what you have to do is return ApoB to normal. So, and knowing the genes that may be causing this does not help you. At the end of the day, you say, well, I still have to lower
Yeah.
ApoB. The only case it could help in the people who really have the very high, if you do genetic testing and you ascertain, aha, there's the abnormal gene that's causing you, you can do what's called cascade testing. You can check other family members for that gene. And you may, aha, no wonder you're my relative. You have the same gene causing your LDL cholesterol. But to be honest with you, they're not always available. They can be very expensive, those tests also. I think you just have to recognize LDL cholesterol or ApoB or non-HDL cholesterol has to be lowered as much as you can. It's a little more difficult in the people in the FH to lower it, and you also have to lower it tremendously more than you do with people who have an LDL cholesterol in the intermediate range. Now, to put in perspective the numbers you said, hey, the intermediate range would be 130 to 190. If we look at population percentile cut points, that means if we measured LDL cholesterol in giant populations or in, say, some countries, we measured LDL cholesterol in everybody in that country, you would find one person had the lowest level you see and one person has the highest level. And everybody else is in between there. And it's usually a bell-shaped curve where most are in the middle and the people with the low or the very high are at the extremes of the population percentile cut points. So what we do is we put them into deciles. So if you are in the lowest 20th percentile of LDL cholesterol, non-HDL cholesterol, or ApoB, you're at pretty low risk for heart disease. If you're above the 80th percentile, well, that's pretty much you're in the FH range. You're in really high trouble for this. In between, that would mean you're between the 30th and the 79th percentile. To be honest with you, we know from the genetic examples that if you are born with the right genes, you don't make very many ApoB particles. That's called hypo-beta lipoproteinemia. They go through life from the moment they're born to the moment they die with perfect LDL cholesterol levels, defined as below 50 milligrams per deciliter. The ApoB would be below 45 milligrams per deciliter. Those people have no coronary artery disease, no atherosclerosis, and they suffer nothing because their lifelong LDL cholesterol is very low. So that's the bottom fifth percentile of the population. So you would pray that you pick parents that put you in that bottom fifth percentile. Most of us were not that lucky. So we're somewhere in the other population percentiles. So I like to see you below the 20th. When you start getting to the 40th percentile, I think over time, that's the person who's going to have heart attacks when they're 60 or 70 years old. Now, listen, I'm going to be 79 next month. I haven't had a heart attack yet. Thank God. I'm knocking on wood. But I wouldn't want to have a heart attack today because it would make me sicker. Maybe it would put me into heart failure. It might kill me, for God's sakes. So if you're going to ignore LDL cholesterols in even a 30th, 40th, 50th percentile for decades, those are the people who are probably not going to have longevity or health span when they get to be an old person. They won't be terribly healthy. So I think, and certainly the guidelines are moving in the direction, and the world of lipidology is lower is better, and the longer it's lower is even better. So that means starting to look at lipid panels very early in life, probably in early adulthood, age 20, 21, which is typically the age, hey, you're an adult now, you're not a teenager anymore. And if we start to see, what if you picked up an FH at 20 years old? You would treat that 20-year-old with drugs. So maybe it's borderline. You would try some lifestyle for X number of months and see, can you get your LDL cholesterol, your ApoB a little safer. But at a certain point, even younger people, when they start getting the 40th, 50th, God forbid, the 60th percentile levels, to me, that's an indication if lifestyle can't get you lower than that to prescribe one of our lipid modulating drugs. And the more common ones have been around for 30 or 20 years now, incredibly safe profile. Even the more potent ones, PCSK9 inhibitors, have been around for over a decade, and the research way longer than a decade, and there's been zero downside to them yet. And, people sometimes worry, oh, I don't want to lower LDL cholesterol too much. Why not? Because if you were born with low LDL cholesterol and you maintain that, you don't get atherosclerotic heart disease, and there's no pathology that shows up because your LDL cholesterol is very low. So, I use the 20th percentile in otherwise healthy people. But if you came to me and you had LP little a, or you're a diabetic, or your ApoB is very high because your triglycerides are high, I don't wait till you're 50 years old to lower your LDL cholesterol. I jump on you very quickly if you have those comorbidities, which puts you in a higher risk range. So this is why you have to individualize therapy. There's no cookbook that fits for everybody. We have to treat people one at a time. We're not epidemiologists treating populations, or we're treating people one at a time. So you have to respect lipids. We all respect blood pressure nowadays. We all smack any of our patients who are smoking and tell them to stop smoking. And why wouldn't you therefore jump in early in the game with high ApoB, high LDL cholesterol, and start lowering it? What are you waiting for? This is an asymptomatic disease until you wind up in the graveyard or the coronary care unit.
For people with intermediate level LDL and they manage to lower their LDL cholesterol and ApoB, do they have to know that they have familial hypercholesterolemia? And can you even have familial hypercholesterolemia with intermediate level LDL?
Well, the textbooks define familial hypercholesterolemia as an LDL-C of 190. But yes, anybody who has an LDL cholesterol much above 120 to up to 190 if you could do a full sequence genome, you would find several genes that are driving those abnormal lipids. So virtually every lipid disorder is genetic. Now, remember, like any gene, the environment you put that gene in can make it worse. So if you have some minor genes, but now also you're obese, you're diabetic, you have hypertension, it compounds the risk of your genetic abnormality. But every lipid disorder has abnormal genes. If you had a perfect genome, you would not have any serious abnormal LDL concentrations, ApoB concentrations. So just assume it. But therefore, I don't think you have to know what the genes are. What you have to know is, your ApoB is too high at your stage of the game, and we'll lower it. We'll try what I think is a diet appropriate to your metabolic issues. And if that doesn't get your ApoB to a safer level, your LDL cholesterol, then we're going to start pharmacotherapy. And that's a whole nother lecture as to which drug to choose, what dose do you pick. It gets complicated because we have, it used to be easy in 1987. We basically had one drug, statins. I mean, there were fibrates and niacin, which have since disappeared. So, although we were using them back then, that's all we had, but they're gone now for the most part. So, statins came around in 1987 in the United States, and ezetimibe came around in 2000. So that's been here 25 years now. So great safety records to use them.
And the treatment is if they have familial hypercholesterolemia or if they don't, as long as they lower the LDL cholesterol and the ApoB, it's the same. There is no difference in treatment as per se, right?
With rare exception, for the overwhelming majority of people who have what is called heterozygous familial hypercholesterolemia, that means you have one gene contributing to your extremely high levels, one allele contributing to it. There is something much rarer, thank God, called homozygous familial hypercholesterolemia, where you inherited genes from both parents that basically have cause defects in your LDL receptors or your ApoB protein, and they have incredibly high LDL cholesterol. They're the people with LDL cholesterols in the 300 to 400 milligram range, molar concentrations through the roof. There are drugs that can be used for them that are not used for heterozygous FH patients. And typically, the homozygous FH, they're dead by their teenage years to their second decade. So that's a pediatric disorder, and that requires very specialized care by lipidologists who are pediatric lipidologists. And there are a couple of drugs they use that we would never use in adult patients. The ultimate treatment that you could use for an adult, say you threw the kitchen sink of drugs at an adult with very severe heterozygous familial hypercholesterolemia, and despite triple or therapy, that would mean a statin, ezetimibe, a PCSK9 inhibitor, maybe even you throw in bempedoic acid, 4 drugs, and your LDL-C is still at a dangerous level. There is something called LDL apheresis that can be offered to those people. It's sort of like a dialysis. They put big tubes in your arm, and they suck out your blood, and they remove the LDL particles, and then they give you the blood back. So, but that has to be done like every couple of weeks because LDLs turn over very quickly. So it's not like, hey, I can go twice a year like you could with a phlebotomy if you had polycythemia. No. So it's a really aggressive pain in the neck type treatment. But if you have very high LDL-C and you keep having stents or myocardial infarctions, strokes, that is what can be offered. Of course, there's a problem with that too. That's not offered in every town in the world. You have to go to specialized centers that are doing that. So if you happen to live in a big city where it's not too far away, you're lucky. But if you live in a rural part of most countries, you're probably not going to get LDL apheresis. LDL apheresis can also be used for the people with extremely high lipoprotein little a that are having recurrent events. So that's an outside treatment for them until any of these new drugs prove to be successful or not.
You talked about the LDL particles. So what is an ideal level for LDL particles? What is a borderline and what is very dangerous high level? And if you measure the ApoB, do you need to measure the LDL particles as well?
I'll answer that last question first. No, you do not. They're the same thing. ApoB is an LDL particle count because 95% of your ApoB particles are LDLs. So you have the number of atherogenic particles by doing either of those tests. ApoB is probably more widely available than LDL particle counts, which use more complex methodologies, such as nuclear magnetic resonance or ion mobility transfer. Again, maybe if you're in a big city with a sophisticated lab, it's easier to get than elsewhere. In the United States, third-party payers tend not to cover those more sophisticated LDL tests, so they're a little more costly. I would bet in many countries that have socialized medicine, they're going to make it hard to get those type of particle counts. But if you get them, they are the same. So if you are getting them, what are the metrics you have to worry about? We're going to use the same concept, population percentile cut point. So ideally, you would want your LDL particle count to be under the 20th percentile. That would be typically an LDL particle count of around 1,000 to a maximum of 1,200 nanomoles per liter. So that's what you would look for. And if somebody had very high and you're treating it, that would be your goal of therapy to get it down to there. With respect to ApoB, typically, even in most countries, it's measured in milligrams per deciliter. I'll tell you how to convert it to molar concentration in a moment. But the 20th percentile of ApoB is around 70 milligrams per deciliter. So that would be an ideal ApoB. Now, again, if you came to me and you had a couple of stents or very high LP little a, I would want to drive your ApoB down below 50 milligrams per deciliter because you're a super high risk person. But for the run of the mill person, that would be an ideal ApoB. And you start to worry about ApoB when it starts to go above 90 to 100 milligrams. Don't read the guidelines, which might be telling you 120. 125 is like a 90th percentile ApoB, for God's sakes. So those are the cut points for that. By the way, if you do happen to get ApoB in milligrams per deciliter and you like to know, I want to compare it to the LDLP done by NMRs, all you have to do is the molecular weight of ApoB, the non-glycosylated molecular weight, is about 513 kilodaltons. So if you take the milligrams and you divide it by 513 and you multiply by 1,000 to change deciliters to liter or milliliters to liter, you can easily, then you would get an ApoB particle count of, and if you're lucky, it would be 1,200 nanomoles per liter. And if it's higher than that, you should lower the ApoB. So that's easily how you calculate. A little bit of a caveat there. When you're measuring ApoB, you're measuring VLDLs plus LDLs. But 90 to 95% of the ApoB particles are LDL. So if you did my calculation, divide by 513, multiply by 1,000, the nanomole concentration is total ApoB. If you really wanted to know LDL ApoB, you would multiply that by 95%. And that's my LDLP in nanomoles.
Other than standard lipid profile, ApoB and lipoprotein little a, is there anything you would recommend to measure as well, other important lipid markers?
Yes, I always joke, all I need is one time LP little a. I need your ApoB, but I also need a triglyceride level. Triglyceride levels, and there's two reasons you need a triglyceride level. There are some people who have significant genetic abnormalities that raise their triglycerides. Typically, their triglycerides are well above 500 milligrams per deciliter, even much higher, could be in the couple thousand milligrams per deciliter. Now, they are more, because that is genetic, early in life, they start to get pancreatitis from their very high triglyceride levels. So now some adults make it to adulthood, and maybe not having had pancreatitis, so you don't know until you measure triglycerides. But if you see a trig that's well above 500, your first mission as a clinician is to make the triglycerides be less than 500, because then you take away the pancreatitis risk. Trigs of 1200, 800 are usually not associated per se with coronary disease. They are mostly it's the pancreatitis risk. But once I make your trigs less than 500, you're at no risk for pancreatitis, but then you become at high risk for coronary disease because virtually everybody with a trig under 500 has a high ApoB concentration. So triglycerides can be a surrogate for ApoB, like LDL cholesterol is a surrogate for ApoB. So the average, typical high triglyceride level that most clinicians see is between 150 and 400. Those are the diabetics, the insulin resistant people in the world. Maybe they have a minor triglyceride gene abnormality. But if you would measure ApoB in them, oh my God, it's high. And triglycerides are just a signal that please measure ApoB. If you can't get ApoB, you calculate non-HDL cholesterol, which is not affected by triglyceride levels. So, and if non-HDL cholesterol is up, your ApoB is up, and you would obviously want to lower your non-HDL cholesterol. So even though triglycerides are very important risk markers, they are not risk factors. And you define risk factor as something that is causal. And if it's causal, it's a goal of therapy. So since triglycerides are not causal, they contribute to risk. They're a risk marker. When you have high triglycerides, your goal of therapy is ApoB or the ApoB surrogate, non-HDL cholesterol. And no guideline offers a triglyceride goal of therapy. They all tell you when triglycerides put you in the world of risk. But when they say, oh, what do you do for a person with high triglycerides? Lifestyle and if needed, drugs, and you get their non-HDL cholesterol or ApoB to goal. So that's a little nuance there for that. So that's the why I need a triglyceride. Now, I put a lot of importance on non-HDL cholesterol today because most people are not doing ApoB levels and the non-HDL is free. But there is a lipid metric you need to calculate non-HDL cholesterol. You need total cholesterol and you need HDL cholesterol. So in essence, you need the full lipid panel. So you take total cholesterol, you subtract from it HDL cholesterol, and then you have your non-HDL cholesterol. I could joke the only metric you do not need that serves no purpose in the lipid panel is LDL cholesterol because non-HDL cholesterol supersedes it. That is the important cholesterol metric. So that's the Dayspring way of looking at lipids and lipoproteins.
Yes. And ApoB, sometimes they measure it gram per liter. Can you convert that to milligram per deciliter? I know that LP little a, you cannot convert it because one measures the size and one is the concentration.
Yeah, well, look, a thousandth of a gram is a milligram. So you divide a gram and then you divide a liter to the deciliter. They'll also divide it. So it's a simple changing grams or liters to milligrams and milliliters. That's very easy to do.
Yes.
You don't need I mean, you can do that in your head. You're just moving a decimal point.
But with the LP little a, you cannot do it because it's different.
Now,
Yes.
totally different because
Mm.
LP little a doesn't have a standard molecular weight. Because the ApoA protein has variable molecular weight due to its size, that's a variable. Also, an LDL particle doesn't have a standard molecular weight. An LDL particle consists of thousands of phospholipid molecules, thousands of triglyceride molecules, thousands of cholesterol molecules, a whole bunch of other molecules, including glycosylated molecules. It has ApoB, and and LDLs are a heterogeneous population, so no two LDLs have the same molecular weight. So you can't use molecular weight to change those other LP little a to something. I'll tell you this, people are going to smack me for saying this, but so if I had to do that, There is no absolute molecular weight of LP little a, but if you want to say the average molecular weight, you could take your LP little a concentration, multiply it by 2.5, and then you would get your LP little a particle count. If you had milligrams, if you're measuring LP little a in milligrams per deciliter, multiply it by 2.5 and you get your nanomoles per liter. It's not exact, but it puts you in the ballpark, you know. The other thing, and the experts will tell you, whether labs are reporting LP little a in milligrams per deciliter, the weight of the particle, or the molar concentration, the number of particles, they both correlate pretty well with one another. So if you have a high LP little a mass in milligrams per deciliter, you're almost certainly going to have a high molar concentration, and vice versa. If you have a high molar LP little a concentration, your milligrams per deciliter is going to be high. Only if you're in a borderline level where there might be some variance. But in people who have really crossed the high thresholds, they're going to be high no matter how you're measuring it.
I heard you say in the beginning that the normal level is up to 50. Many labs reported up to 70.
Nanomoles perfect is under, for LP little a, less than 50. The high risk concentration, probably when you start to hit 75, you worry. For sure, when you hit 125, they would put you in the high risk zone. For milligrams per deciliter, it would be pretty much above 30 milligrams. You're entering the world of risk. By the time you hit 50, you're in the high risk situation for milligrams. So, and remember, there are genetic variations. So in African Americans who really 1 out of 2 have high LP little a, no matter how you measure it, whereas maybe 30 milligrams per deciliter ought to be the high risk range for an African American, So, and Asian Indians, and there are different populations throughout the world who just genetically produce high concentrations of apoprotein little a. So you worry about them a little more.
And the higher the concentration, the more dangerous the level is.
Yes. Just like LDL particles or ApoB, the higher your LP little a, the more likely you are to have an event. And what I didn't, we've been talking so much about atherosclerosis, and that is the highest risk of LP little a. Way more common to get coronary atherosclerosis than cerebral atherosclerosis. You can get strokes, but the incidence of strokes is lower than the incidence of myocardial infarctions in these people.
With LP
But the other, the what?
With the LP little a, right?
Yes, with the high LP little a. But the other thing you have to worry about high LP little a is it can invade the aortic valve, the main valve through which when the left ventricle pumps, blood goes out into the aorta. It's a crucial valve. You never want to have aortic valve pathology. And some of them are congenital defects, bicuspid valves and things like that. In the old days, it used to be rheumatic fever. Maybe in certain parts of the world that still occurs. But right now, other than the bicuspid valve, probably the third most common cause of aortic stenosis requiring valve replacement is high LP little a. Another reason why everybody should get an LP little a tested early in life when you become an adult, because you would not only monitor that patient for atherosclerosis, you would keep a close eye on their aortic valve, either by listening with a stethoscope for a murmur, or of course an echocardiogram can give you more information on that. LP little a is not usually recommended to be tested in children, even though it is a major cause of stroke in children, but pediatric strokes are kind of rare. So if a kid has a stroke, you absolutely want to do an LP little a. But the reason why it's not totally recommended, we have no treatment we would give to a kid even if a poor child had high LP little a, what would you do about it? There's no approved therapy. I mean, you'd lifestyle, but I don't think lifestyle is going to avoid that complication.
How do we explain sometimes when it fluctuates? Is it normal for it to fluctuate? And what is a normal fluctuation?
We used to say no, get it once in your life, and the guidelines still say once in your life is plenty, but some recent study shows there is some variability. So you could have low LP little a, intermediate LP little a, and high LP little a concentration. So here's what you have to know. If you have low LP little a, it never becomes high. That's incredibly rare. If you have very high LP little a outside of some investigational therapy, it never becomes low. So you can't wake up one day and be at no risk for very high LP little a. But there are a few people who have LP little a in the intermediate zone. Sometimes they fluctuate down into the low risk zone. Sometimes they fluctuate up into the high risk zone. So, should you repeat it? Uh, I guess you could say, well, yes, but if I saw it was going into the high risk zone, maybe I'd start suggested therapies. But how do you know in 2 more months it will be back in the intermediate zone? Because there is a little bit of variability if you're in that gray zone. The one perhaps time they say you should change it, and that would be in women. At menopause, when women lose estrogen, LP little a tends to go up a little bit. Now, again, if you're in the low risk range, it never goes into the high risk range. You might go into the lower end of the intermediate range, and I don't know what you do about that. So, but that might be, hey, if you had a woman who had an LP little a premenopausally, maybe you want to repeat it postmenopausally. That's the only other circumstance. You have to understand that LP little a, meaning apoprotein little a, is what we call an acute phase reactant. It means if there's something else of especially an inflammatory or incredibly traumatic something going on in a person, never do a lipid profile, never do LP little a. If you have an infection, simply a sore throat, a cough, a bronchitis, your LP little a could be very, very high because your liver is making all sorts of immunologic proteins, and
Thyroid
their
as well.
protein making apparatus just makes every protein. So you would want to get over your infection for a couple of months and then do the LP little a test.
And even with thyroid disease, right?
The same, a little bit more with the LDLs in that, but again, unless you have gross hypothyroidism, uh, borderline thyroid, the type of things we see in most patients because TSH is frequently being checked. You're not having people walk in with myxedema or myxedema coma anymore. They're coming in, they feel a little tired. You do their TSH, it's a little bit high, and you get them on therapy. So that could have some influence on LDL receptors, which clear your LDL particles, but LDL receptors don't clear LP little a. So I'm not aware that hypothyroidism has much of an influence on LP little a, but it certainly does on ApoB and LDL cholesterol. That is called a secondary cause of hyperbeta lipoproteinemia. As I mentioned before, any secondary cause should be treated first if it's treatable. There are liver diseases that are not treatable that then you just have to take care of ApoB regardless.
About the therapy, when you said that there is proven therapy, the ones that are used now in practice is PCSK9 inhibitors. These are the only ones at the moment, and the rest, as in clinical trial, is that right?
Yeah, with respect to LP little a, there is no, in the United States, FDA approved therapy to lower LP little a. That doesn't mean if there's a drug on the market, doctors couldn't use it off label for whatever they want to. So we do know several of the studies have shown PCSK9 inhibitors do have the ability to stop the production of apoprotein little a in the liver or to stop its linkage to the ApoB particle in the liver. So therefore, by about 25 to 30% magnitude, PCSK9 inhibitors tend to lower LP little a. Now, we have no data yet, no outcome trials that show lowering LP little a will reduce MACE. We all believe it will. MACE is major atherosclerotic coronary events, cardiovascular events. So we all believe, because the Mendelian and epidemiologic studies suggest LP little a is causal, that it would be good to lower LP little a. We do not know how much you really have to lower LP little a to reduce MACE. The ongoing trials with super potent therapies will teach us that. But until they come, there are people who are having events due to LP little a. So why wouldn't you use a PCSK9 inhibitor to at least if nothing else, it's going to dramatically lower ApoB, which is what you should be doing to anybody with LP little a. And in addition to lowering ApoB or LDL cholesterol, it would also lower LP little a. We hope that's good. There's some post hoc data from a couple of the PCSK9 trials that suggest it is good, but nobody's going to do a randomized blinded trial using a PCSK9 inhibitor because more potent therapies are coming. So the problem is third-party payers won't, at least in the States, since it doesn't have an FDA indication to treat LP little a, you would have to pay for it yourself, and it's a very expensive drug. So for those who can afford it, they use it. And in the United States, where there are a lot of, and where I practice or advise people, there are wealthy people, as there are in virtually every country. There's always some segment of the population that can afford anything they want. So those people are raising their hands saying, look, I haven't had a heart attack or a stent yet, but I want my LP little a lowered. They've done their own homework. They know this happens. So if they come in and they want to pay for it, there's virtually no downside to a PCSK9 inhibitor. I have no objection if somebody wants to use that. For the run-of-the-mill person who can't afford it, it's probably not going to happen.
Would you say that among all of the anti-lipid agent is if someone has high ApoB and high LP little a, PCSK9 inhibitor would be the preferred first option?
Not according to the guidelines, because the guidelines know the costs of the PCSK9. So the guidelines would recommend if you have high LP little a, your first mission in life is to lower ApoB as much as possible. And so they would want you to go on statin therapy or statin plus ezetimibe therapy. If you can't tolerate a statin, you could swap in bempedoic acid, which can be used in people intolerant of statins. But even that's a very expensive drug. So for the most part, people with high LP little a are put on generic statins and generic ezetimibe, which because they almost always have high ApoB, not always, but most of them do, they would be covered, and they're pennies on the dollar anyway. They're very cheap. So that's the guideline therapy. The guidelines are not at this time suggesting PCSK9. If you read the really full guidelines, which most people don't, there'll be mention that, hey, these drugs can lower it. And therefore, you do, if you want to go off label and use it, you could. But the preferred recommended therapy is statins and statins plus ezetimibe.
That's just because of cost, because the PCSK9, it makes more sense that it will lower both instead of
Yes.
one.
So look, again, depending on the makeup of your practice, if at all possible, I personally would recommend trying to. Most of those people have very high ApoB, so they might need a statin plus a PCSK9 inhibitor, ezetimibe plus a PCSK9 inhibitor. But if their ApoB is not that bad to begin with, you could start a PCSK9 inhibitor by itself.
Mhm.
And if you get LDL cholesterol, non-HDL cholesterol, ApoB to goal, and you lower LP little a by 25-30%, we'd all be happy.
If the PCSK9 inhibitor lowers ApoB target and the LP little a gets lowered, is there any advantage to adding statin at that point, small dose of statin, or no, not
No, if you
necessarily?
achieve ApoB goal, that's your real goal of therapy. So, and in some people, I mean, probably an FH person, you're not going to get to goal with PCSK9 inhibitor by itself, but in the vast majority of people, you could, because it's very potent at lowering ApoB LDL cholesterol. So yes, I agree with you. If you got to goal, I don't have to add a statin. Statins are very safe drugs, been around a long time. There are some minor side effects, the muscle aches. You have to watch, especially those with prediabetes, you have to watch the glucose. Ezetimibe has very few side effects, pretty safe drug to add. So, but PCSK9 inhibitors, about as clean as it comes with a drug. There's nothing for me. I mean, if you read the package insert, it'll tell you some people get a little erythema at the injection site. Personally, I've never seen it, but it is reported.
Mhm.
I personally use a PCSK9 inhibitor, and I don't get any redness.
Yeah. And there is another medication, Inclisiran. That's the one that you use every in the beginning 3 months and then every 6.
Yes, it's also a PCSK9 inhibitor, but now we have two classes of PCSK9 inhibitor. The two that have been around the longest, evolocumab and alirocumab. In the United States, Repatha, Praluent. I don't know if they have other names elsewhere.
Yes, same.
So they are monoclonal antibodies that bind to express LDL receptors, or they can even bind to the ApoB on the circulating L. And by blocking PCSK9, your LDL receptors can recycle a lot more than if you don't block PCSK9. So Inclisiran is a short interfering RNA molecule, which you inject it, but it goes right to the liver. It has a liver-specific molecule that makes a specific receptor in the liver pull it right in, so it doesn't go into other tissues in your body. And it by interfering with the RNA that's involved with the production of apoprotein little a, your liver starts making less ApoB and less LDLs or apoprotein little a, so it can lower both ApoB and LDL particle counts. Or excuse me, I said it interferes with the production of PCSK9, and PCSK9 is, if you inhibit PCSK9, you express LDL receptors more. But it also has the ability, for the same reason of the monoclonal antibodies, to reduce LP little a. Part of the issue with LP little a is we know how it's produced pretty well. Those steps are all outlined in the liver. We don't know exactly how LP little a particles are cleared from plasma. The LDL receptors may grab a few of them, but for the most part, that is not the main exit route of LP little a particles. There are at least 4 or 5 other which have receptors that have been proposed as putative receptors that can bind to and clear LP little a, but none are proven just yet. Maybe it's all of them together a little bit. So until we know what receptors clear LP little a, we can't develop a drug that enhances clearance of LP little a. So right now, the only way to reduce LP little a concentrations is to prevent LP little a particle production in the liver. And all of the PCSK9 inhibitors do that. And other drugs are in development, including there's a new CETP inhibitor that will probably be on the market soon called obicetrapib. It, like all of the previous CETP inhibitors, they have marked ability to lower LP little a by upwards of 60%. So if that ever hits the market, and if it does hit the market, it'll be to use with a statin to treat familial hypercholesterolemia. But just like PCSK9 inhibitors are used off label, I think obicetrapib would be used off label. And it's an oral tablet, it's not an injection. So it also seems, the belief is it prevents the production of apoprotein little a, and the liver makes less LP little a particles. So it'll be a good time to see that come on the market, and we can get further studies on that. I mean, the company is studying it right now, but the only way you get an LP little a indication is you have to show your drug by lowering LP little a reduces MACE. And that takes years to do and very expensive. I don't even know if they'll do a LP little a outcome trial.
And does this one lowers ApoB as well?
Yeah, so it's a beautiful drug. It's way more than all of the previous CETP inhibitors. Lowers ApoB anywhere from 15 to 20, 25%. So you get a drug that lowers ApoB, LDL cholesterol, and you get a drug that lowers LP little a, and hopefully that's important. It'll be again, I don't know how they're going to price it. If they make it as expensive as a PCSK9 inhibitor, nobody's going to use it. But hopefully it'll be a little cheaper and it will get more widespread use, at least to lower ApoB. They just published their study that shows on top of a statin, if you give it to statin plus obicetrapib to FH patients, you get better LDL cholesterol ApoB lowering than you do with just statin alone. So I believe it'll come on the market with an FH indication, but then you can do whatever you want if you're a prescribing clinician.
And how does this average between the other anti-lipid agent lowering 15 to 20%? Are the others also?
Yeah, that's more in line with ezetimibe or bempedoic acid. So, in fact, the company that's producing it is also making a combination tablet where it's obicetrapib plus ezetimibe in the same tablet, and then you'll get as much lowering as a statin gives you. You know.
What is the strongest agent in lowering ApoB?
Look, there are the drugs that are used with homozygous familial hypercholesterolemia. Lomidopide can help lower ApoB a lot. There used to be a drug that inhibited the production of apolipoprotein B that's been removed from the market due to safety concerns. So, lomidopide, which is never used in an adult who doesn't have homozygous FH. So none of us are going to use that to help lower ApoB. So right now it's either if you're looking at a monotherapy, it's the PCSK9 inhibitors. But if you're looking, you really want to blow away, it's a PCSK9 inhibitor plus a statin plus ezetimibe, your triple therapy. Then beyond that, there's nothing more you can do.
Concerns that it goes through, affects the RNA, the genetic.
Which drug are you talking about?
Inclisiran.
Inclisiran?
Yeah.
Yeah. Well, this is the thing. You know, it goes in there, and there's studies right now, the phase 1, phase 2 studies. They're in the process of a phase 3 study. The safety data has been pretty good. No side effects seen with inclisiran, not seen with the other PCSK9 inhibitors, which basically means no side effect. So no, you're only affecting the RNA that's involved with the production of apoprotein little a. You're not affecting other RNAs that are involved with the production of everything else in your body. So there should be no concern about using an siRNA directed against apoprotein little a.
It's not contraindicated specifically to anyone.
No, it would, the only contraindication is if you've used it before and you had a reaction to it. So that's a contraindication to try it again. The minor erythema is not a contraindication. If in some people the injection site becomes real annoying, they're going to say, I don't want to take it. This is where inclisiran might be better because once you're on it, it's every 6 months, typically administered by a nurse, not self-administered. So there might be less of that type of reaction. So, but otherwise, no downside. People worry, of course, that because these drugs lower LDL cholesterol so much, you're hurting other tissues. That is total nonsense. No lipoprotein carrying cholesterol in your plasma can cross the blood-brain barrier. The brain gets zero cholesterol that is made peripherally and is trafficked in the plasma in HDL or ApoB particles. The brain, starting in utero through childhood into adult, produces all of the cholesterol molecules it needs. And it needs a lot. The brain is the second most cholesterol-rich organ in the human body, the liver being the first. So your brain needs cholesterol because it's a crucial part of every cell membrane, especially in the neurons. So, but the brain synthesizes it all. So if I make your LDL cholesterol 10 using a PCSK9 inhibitor and a statin, there's no neurologic consequences. You could not possibly affect the brain. People don't realize their LDLs serve one purpose in the human body, to return peripheral cholesterol to the liver. LDLs perform reverse cholesterol transport. LDLs do not deliver cholesterol to any cell in your body under normal circumstances. So if I make your LDL-C 10, I'm not hurting your kidneys. I'm not hurting your whatever organ you want to point to. I'm not hurting your steroidogenic tissues, your adrenal cortex or your gonadal steroidogenic tissues. Those tissues, like the brain, synthesize all the cholesterol they need. If they needed any backup cholesterol, HDLs are the supplier of steroidogenic tissue, not LDLs under normal circumstances. So you never have to worry there's a downside to lowering LDL cholesterol. If you are significantly lowering it, you are enhancing reverse cholesterol transport. That means it's going to the liver. And the liver can take that cholesterol, make it a bile acid, secrete it to your gut, where it can be reabsorbed and used again or excreted in the stool. The liver can also eject excess cholesterol by itself into the bile. It goes down to the gut. it's altered by gut bacteria, and it's excreted in the stool. So low LDL cholesterol has no downside caused either genetically, because you were gifted with the right genes, or the currently approved LDL cholesterol lowering drugs that work through the LDL receptor. And every drug on the market, statins, ezetimibe, bempedoic acid, PCSK9 inhibitors, either make you upregulate LDL receptors or let them live longer, increases their half-life. That's how, and you clear ApoB. The more LDL receptors you have, you clear ApoB.
When you start anti-lipid lowering agent, your markers is ApoB, and what target?
The average risk, I think you get it 70 below. You're really, and then you do it. I mean, if you a low risk patient, so that would be your goal. Your higher risk patients, people have had events. Maybe you've done imaging and you see they got coronary disease, or they have very high LP little a. Personally, I would want you under the 5th percentile. I would want to make you hypo-beta lipoproteinemia. That would be at least under 60 milligrams. And if you even make it lower, better. The lower, the better. I listened to Peter Libby, who is the world authority on coronary artery disease. He both a researcher, but he still practices at Harvard. And he did a podcast I listened to last week that the National Lipid Association did. And he says in his clinic in Harvard, he strives to get LDL cholesterol at 10 milligrams per deciliter. So that's from the top genius in the world. If you talk to Eugene Brunwald, who many would consider the top cardiologist in the world, he's of that same mindset. Blow LDL cholesterol away. Way lower than what guidelines recommend.
Is little bit above or little bit below target. Can you delay a little bit the injection?
With the monoclonal antibodies, they work instantly. As soon as you check them, the PCSK9 levels fall in a straight line. LDL cholesterol follows by a day or so, goes down to the nadir. It's really low. By between day 14 and day 28, it starts to climb back up again. So you really can't go much beyond a month. You really need to inject it again. Now, look, could you try in an individual patient to, with the monoclonal antibodies, to space it out a little longer? I guess you could, and then you would see, does it work or not? But pharmacologically, if you use all the pharmacokinetics we know about it, you really need it once a month. And of course, that's just the opposite with the siRNA, because in your nucleus in the cell up there, it creates something called a risk unit, and it keeps working for many months. So it doesn't wean off quickly. The PCSK9 drop is several months, not 14 days, so that would be, and look, the cost is the same. So it comes down to, would you rather get an every 6-month injection, or do you want to keep doing it every 2 months? The caveat being the every 6 months usually requires a medical professional. The volume of injection is a little more than what the monoclonal antibodies are. So, but if every 6 months you have to run over, I guess it depends how close the center that does the injections is or not. If you had to travel 100 miles, give me the self-injecting one, to do. There are those in development. There's several. And other than the first one, they're all siRNA drugs for the most part. One is coming that you might only have to inject once a year. So we'll see if it passes all muster for the clinical trials. It's a long way away. Also in the pipeline is an oral PCSK9 inhibitor that is a pill, a daily pill. It doesn't seem to be quite as potent as the injectable ones, but if you want to swallow a pill and you can control your ApoB, remember they're coming on. That's going to be their big indication also, but the LP little a, if you can lower it by taking a pill every day, fine.
Is there a specific PCSK9 inhibitor that works better than the others in lowering LP little a?
The first one that's coming is an oligonucleotide, antisense oligonucleotide called pelacarsen. That's in late stage 3. It was supposed to report out this year. They've delayed it till next year. So next year, we ought to know where pelacarsen has the ability to lower lipoprotein little a by upwards of 80%. So is that enough? Now, though, there are some of the siRNAs that are in development that lower it more than 90%. So are you going to need more than 80% lowering? Only time will tell. We have to wait for the trials. But we will get the pelacarsen data next year. And the two important things are, does it work? Did it reduce heart attacks, strokes? There's a sub-trial looking at aortic valve stenosis. That'll take longer to complete. And we'll know. What we'll also know is how much do you really have to lower LP little a to get benefit? Do you have to make it 0 or below 50 nanomoles per liter, or do you just have to bring it into the intermediate zone or not? Only time will tell.
Mhm.
That will probably only be the people in that trial are super high risk. They've all had infarctions, severe unstable angina. That is not a primary prevention study. So if it works and the FDA approves it to use, they're probably not going to approve it for a primary prevention crowd, and that's going to create frustration. It's liable to be a very expensive drug, more than a PCSK9 inhibitor. I don't know that, I'm guessing, but
From the current one, is there anyone superior to the other in lowering LP little a between the
well, the only current one is PCSK9 inhibitors. So the monoclonal antibodies do it a little bit more than Inclisiran does. They lower ApoB a little bit more than Inclisiran does too. So, but a little bit, not much. So
and
you could pick a PCSK9 inhibitor and you're fine.
is there any advantage for the Inclisiran other than you have to take it like every 6 months? Is there any advantage to the other two?
That's the major advantage. A doubter would say, look, the monoclonal antibodies have been around for over a decade in trials longer than that. The siRNA is much, hasn't been around that long. So might there be some longer ramifications? I guess not, but that'd be, if you want to debate it, should I use an antibody or a Inclisiran siRNA? Sometimes in the United States, the third-party payer decides which one they'll pay for. They might pay for an siRNA and not for the monoclonal antibodies, or vice versa. So, and I know that myself, having been on a PCSK9 inhibitor, when I first got it approved, it was the monoclonal antibodies. But all of a sudden, when Inclisiran came around, and every year in January things change, they said no, Inclisiran is now our PCSK9 of choice. And then the following year, when I changed carriers again, I had to go back on the Repatha. So now they all work. But even in my case, the Repatha, the evolocumab, worked a tad better than the Inclisiran. Not much, but a little bit.
Many scenarios that the lipoprotein little a will be isolatedly high because they're interconnected.
Yeah, but no, there are such interested in just available as a preprint, and I believe it might have been the European Heart Journal. Dr. Nordstrom, who's a world expert on LP little a, they published a nice article that shows the risk of LP little a is independent of LDL cholesterol, ApoB, and inflammatory markers like C-reactive protein, and of course HDL cholesterol. So even if you have high LP little a, if your ApoB is normal, you're still at significant risk from LP little a. Remember, before you asked me what's a normal LDL particle count, and I said, if you're lucky, it's around 1,000 nanomoles per liter. That's the 20th percentile. So if you have a normal LP little a, it's less than 50 nanomoles per liter. So you could see LP little a is an extreme minority member of the LDL family. But let's say you had a really high LP little a. It's 250 nanomoles per liter. But your LDL particle count is probably 1,200 nanomoles per liter. So even high LP little a, you could have a normal LDL particle count. So yes, there is risk with high LP little a. So this is then the real question comes, well, how would you treat that if ApoB is normal? Maybe lower ApoB even a little more than what's there, or maybe that's until they prove it's no good, I'll use a PCSK9 inhibitor to try and lower LP little a in that person. but it's a brand new publication. It within the last week just came online.
Is it more difficult to lower ApoB if you have lipoprotein little a with lifestyle?
Lifestyle doesn't work with LP little a. All the
No, I meant
guidelines
with
tell you that.
if you have lipoprotein B, the ApoB, if you have borderline.
Okay. Yeah, look, lifestyle is not going to help you with LP little a. Lifestyle can sometimes help you with high ApoB. It depends on the cause of it. It really can help you if it's driven by high triglycerides or insulin resistance, prediabetes. Lifestyle is crucial there. Otherwise, look, for cardiovascular disease, it's always good to have a great lifestyle. So you should, I mean, if you want to recommend a generic diet, most people would go to the Mediterranean diet or the DASH diet. But, you're dealing with ethnicities too. What is a great diet for one country may be totally impractical in another country. So
Mhm.
the clinicians within a country should know what diet has a good chance of success or not. So ultimately, if you don't get to ApoB goal with your lifestyle, that's when you're going to use drugs. With LP little a, you're going to need drugs to lower ApoB in most cases. So, and for sure to lower LP little a, you would need a PCSK9 inhibitor there. So sooner or later, you're still going to be back on the PCSK9 inhibitor to get your LP little a under control. Uh, and ApoB is going to be your goal until these other trials finish and give us, is there going to be an LP little a goal of therapy? One day we'll know.
Does weight loss temporarily raise LDL cholesterol or lipoprotein ApoB?
Extreme weight loss can transiently jack up LDL cholesterol. Paradoxically, women with anorexia nervosa, severe eating disorders can have high LDL cholesterol, but they're the extremes. That doesn't apply to the everyday person. So, no, your LDL cholesterol, remember, your LDL has a half-life of 2, 3, 4 days, so it drops very rapidly with proper lifestyle. Now, if your lifestyle has nothing to do with your LDL cholesterol, nothing is going to change. And there, as I alluded to before, most of the causes of LDL cholesterol are genetic, which may or may not be influenced by lifestyle. So you have to always try it and see whether it works or not, but it may not. By the way, if you are the drugs that you're going to use to lower ApoB, there is one that can sometimes increase LP little a, and that is the statin therapy. That as good as they lower ApoB, if you're following LP little a concentration, in some people, not everybody, you can get an escalation of LP little a particle counts by anywhere from 10 to 30%.
Oh,
But remember, it's a minority particle. So say you have an LP little a of 100 and it raises it by 30%. You go to 130. There's no difference in risk for the most part. But the statin would so dramatically lower your LDL particles that don't have ApoA attached that at the end of the day, statins reduce risk in people with high LP(a), even though they transiently increase LP(a) particle concentrations. The two guidelines that have addressed this, the European LP(a) guidelines and the National Lipid Association LP(a) guidelines, say under no circumstances should anybody using a statin to lower ApoB in people with high LP(a), should they stop the statin if LP(a) goes up? Because it just goes up a little bit, but it's dropping the LDL particle concentration, which is by far the vast majority of atherogenic particles.
is there a relation between high ApoB and hypertension?
The relationship is one of the, by far, probably the most common cause of hypertension is insulin resistance. And most people with insulin resistance have high ApoB levels due to their triglyceride-rich lipoproteins. So that would be the connection. Is your hypertension related to insulin resistance? If so, you almost certainly have an ApoB problem. If you are a non-insulin resistant person with hypertension, I don't think there's a link between the two, but realize they are, even if they're not linked, you can still have non-insulin resistant hypertension with high LDL cholesterol. They're both causal for atherosclerosis, so you got to lower both.
Mhm.
But only in the insulin resistant people, I think, are they tied in. I mean, if you had atherosclerotic renal artery stenosis, which cause hypertension, you would have high ApoB and hypertension, but that's a rare example.
Do we have any evidence that if we lower ApoB that will improve blood pressure?
Yes, I think you're improving arterial health and
Mhm.
endothelial function by lowering ApoB. Probably get greater nitric oxide production, which, if you look at all of the lipid data, there are always a millimeter or two drop of systolic blood pressure. And over time, that's a pretty significant drop.
Thank God I ran into your videos because the normal range in most hospitals, they say the ApoB is until 140. And then I watch your videos and you say it should be below 80. And I'm saying,
Yeah.
way
I
high.
I can send you the cut points from NHANES or MESA studies, and you post that with these videos, and we have to get those are old numbers. We have to
Get
get
rid of
way
them.
beyond that. The problem with guidelines, every time they get more aggressive, everybody criticizes them, and they get a lot of heat. For some reason, the rest people who are not astute physicians in lipids, they don't feel or fear lipids.
Mm.
Uh, they would, and they go on. This is the food industry who's making half of the wrong stuff we should never be eating. They would go on strike or call their congressman if the guidelines recommended more aggressive lowering. So they have to be careful. And as you start making this lower, it's pretty much everybody on the globe is probably going to need pharmacological therapy. As we've proven time and time again, most people might do a diet, but they don't sustain the diet. So you never get long-term benefit from diets in most people. So you get into those socioeconomic issues and the cost of even generic drugs. And globally, we can't put everybody in the globe on anything.
Yeah.
We wouldn't even be able to reach half of them.
Is there any dangerous level or downside to lower it too much? Or is there a level when it's too low?
Now, with LDL cholesterol, there's no low level that can harm you. Now, with ApoB, yes. Remember, ApoB is VLDL particles plus LDL particles. You need VLDL particles to traffic triglycerides from the gut or the liver to the muscles, because the muscles use the fatty acids on triglycerides to create ATP. They oxidize the fatty acids, and that's where muscles get the energy to move. The VLDLs and the chylomicrons coming out of your intestine also deliver fat-soluble vitamins that you have eaten to the various tissues. So, therefore, I don't want to ever make ApoB below 30 because if I drop it below that, I might be dropping VLDL particles too low, and they serve a distinct function. There is something called A beta lipoproteinemia, where a person genetically just doesn't make ApoB, and they have a lot of consequences, neurologic and vitaminosis issues, because they're not transporting the fat soluble vitamins to their tissue. So, yeah, I think 30 with an ApoB is good. With LDL cholesterol, uh, yeah, really low doesn't matter. I will also tell you this, the assays that measure LDL cholesterol are not terribly effective when you start getting to very low LDL. There's great variability. It might be 10 today and it'll be 30 tomorrow. So, and that's just lab assays. So, this is why I think with LDL cholesterol, much below 50 is whether it's 40, 30, 10, I'm happy. If it's 40, I don't necessarily try to make it 10, you know. But ApoB, if it was 50, I would try and make it 30 in a very high risk person, but I wouldn't go down to 15, 10 with ApoB.
About the test, that is whether to find out if you're over-sensitizer or absorber. Let's say someone doesn't have access to this test and he started statin and he's a absorber and the statin doesn't work very well. Is it fair to switch to the other
Yes.
agent or just to add on?
No, you're totally correct on that. What are the causes of hyporesponse to statin? One can be very high LP little a. but you still usually lower ApoB or LDL cholesterol in those. But if it doesn't go down as much as expected, if you haven't checked, you should check LP little a. You should rule out all the secondary causes of hypercholesterolemia if you haven't already. But yes, it could be that person was not a hypersynthesizer. If you don't have a lot of HMG-CoA reductase, the main cholesterol synthesizing enzyme, which statins inhibit, statins aren't going to work very well. So in that case, they're likely a hyperabsorber. So ezetimibe, you would be a super responder to ezetimibe. Conversely, if you're a hypersynthesizer, you would be a hyporesponder to ezetimibe, whereas the statin would work very well. But if you use a statin, sometimes the body increases absorption, which, hey, the statin worked great for like 2 or 3 months, and then all of a sudden it's not working as well. That's because your body is now reflexly hyperabsorbing. You add ezetimibe. Likewise, if you're going with ezetimibe monotherapy and a hyperabsorber, wow, look how good this worked. But after 3, 4, 5 months, it's not working as good. There's a little bit of reflex hypersynthesis of cholesterol, so you add the statin.
Mm-hmm.
So most people are not measuring the markers of synthesis or absorption. So it really makes sense if you have a high ApoB that needs pharmacological treatment to use the lowest dose of a statin plus the ezetimibe. 10 milligrams daily is the standard dose. You can get away with less if you have to.
Mm-hmm. You start them together is the best way, or?
I do, yeah, because the side effects starting them together are no different than if you went independently. So, and one of the unusual side effects, you have to monitor glucose on a statin. Ezetimibe does not raise glucose. Bempedoic acid doesn't. But in some people, usually in insulin-resistant people, pre-diabetics, glucose can start going up on a statin. You still get the MACE benefit from the statin, but all things considered, especially in younger people, you'd rather not increase glucose. So you might get off of the statin and see what ezetimibe does, or you use to the combination tablet bempedoic acid plus ezetimibe. They do make a combo tablet.
You start this combination because of the phenomena you just explained, because sometimes it works for 3 months and then it will get.
You'd have to try it. That doesn't happen in everybody. So look, if I went with a statin monotherapy and you had a great response, I mean, you're going to probably repeat it every 6 months. If it, oh my God, it went up, then you might think, well, you got to go to combination therapy. So it happens a lot, but it's not a golden rule that it happens in everybody.
PCSK9 inhibitor works better with the over-synthesizer or absorber?
The answer to that is we don't know, but I was one of the authors on a paper, Michael Davidson's group, a few years ago, where we looked at markers, biomarkers of cholesterol synthesis and absorption. And for absorption, you look at plant sterols, because plant sterols should not be in your circulation because you're an animal. You shouldn't be absorbing phytosterols. If phytosterols get in, you know your absorption mechanism is broken. You're overabsorbing cholesterol too. So we did show a link with PCSK9 inhibitors may also reduce the absorption of cholesterol. For what that's worth, anybody who wants that, send me an email or message me, and I'll send you the manuscript that we investigated that.
Do you have a go-to combination generally?
My favorite statin is rosuvastatin, and I use the 5 milligram dose. That you can get almost 30% ApoB lowering by itself, 5 milligrams. If you went to 40 milligrams of rosuvastatin, you get like 45, 40%. So it's not a big difference. But if you took 5 of Resuva and you added 10 of ezetimibe, you do better than Resuva 40 milligrams would do by itself as far as lowering LDL cholesterol or ApoB. So that's my favorite combination. Resuva is a pretty clean statin. It's been around a long time. All statins have the same side effects. Pitavastatin, still a branded statin in the United States, is the cleanest pharmacokinetically. It does not have virtually any drug-drug interactions, perhaps other than cyclosporine. And very interesting, the study was done in Japanese people, But pitavastatin does not raise glucose, at least in people of that ethnicity or race. So if you had somebody where a statin raised glucose, but you still wanted to use a statin, it might be worthwhile going to pitavastatin. Not pravastatin, pitavastatin, P-I-T-A-V.
Do you have a favorite PCSK9 inhibitor? And if it's still high, a favorite add-on to PCSK9?
Yeah, I'm still with the monoclonal antibodies. In general, I've like evolocumab, Repatha, but again, if a third-party payer told me I had to use erolocumab or Praluent, fine, I would have no objection. And if I'm gonna, that doesn't get me to where I gotta go. I would measure absorption or synthesis markers to decide whether to add a statin or ezetimibe. But if I didn't have that, I would probably go with low-dose statin first. It lowers ApoB a little more than ezetimibe does, so I would go with 5 milligrams of rosuvastatin. And then if that didn't work, rather than double the dose of Resuva, you get very little additional ApoB lowering, and then I would add ezetimibe.
How much of hyperlipidemia is genetically determined, and how much of it is our lifestyle?
Michael Davidson, my mentor, one of the world's top lipidologists. Peter Attia, man, I respect and know so well. We believe it's all genetic. Now, and lifestyle can worsen genetic lipid abnormalities, but somebody like a lot of people are like yourself, without pharmacology, you're not going to get to a desirable ApoB goal. So I think any excursion of ApoB, LDL cholesterol, and of course LP little a is all genetic. Now, we may not be able to find the SNP that is out of whack with you. You'd have to do pretty widespread testing to look for, but sometimes you get 2, 3, 4 minor SNPs that each one by itself would not screw up lipids. But when you start getting 2 or 3 of them together, you're either overproducing these particles, or most of the time you're not clearing them. There's an LDL receptor production or PCSK9 issue.
Can someone have normal ApoB, and with time, these genetic will start to activate and cause the ApoB?
Only if you're born with normal ApoB, that means you have good genes. And when you're 50 years old, you should still have it if it was all genetics. But what happens is 2 things. One, we start exposing our bodies to the environment. We don't exercise, we don't sleep properly, we overeat. So that can send anybody into abnormal lipids, even if you have minuscule genetic abnormalities. And also the aging process ultimately starts to affect LDL receptors and ApoB, the molecule itself. So even with aging, ApoB can escalate by itself. So this is why LP little a, once in your life right now, ApoB, you have to keep repeating it. If you're good, yearly is fine, but you want to keep an eye on it at least once you hit adulthood. And the pediatric guidelines want virtually every kid to have a standard lipid profile by around the age of 8, just to rule out FH. They don't recommend ApoB, so you could, wait till you're 21 to do an ApoB. But if a kid has a high LDL cholesterol, their ApoB is going to be high. Children by the age of 5 have developed the adult level of whatever LP little a is going to be. So again, if you're going to do a lipid profile at age 8 in a kid, why not do an LP little a? You wouldn't do anything about it, but at least when he gets in his teenage years, you could start maybe watching a lifestyle in the kid, to improve everything else other than LP little a. And by the time that kid grows up, hopefully we'll have an LP little a therapy.
Can environmental toxins cause hyperlipidemia, pollution, microplastics?
That's a world. Probably they can aggravate it. That's a part of epidemiology that's in its infancy right now, and all these microplastics and everything else that are all over the planet Earth and getting into our bodies, no doubt affect a lot of things adversely, but I don't know anything that ties them exactly to lipids just yet. And if I did, what would I tell you to do? Fly to the moon and live there where there are no. Yeah, right.
If which range would you say that there is a room for lifestyle improvement, and which range would you be more aggressive that no medication is now needed?
Again, I want you below the 20th percentile if you don't have other cardiovascular risk factors. So that would be an ApoB of 70.
Mm-hmm.
That would be nice. Look, if I got you down to 80 and you didn't have hypertension and you weren't a diabetic, okay, I could probably live with that and I'd watch it.
If ApoB is 120 and he wants to go on lifestyle adjustment for a few months, or it's better just
Sure. No, I think you should always try lifestyle because you never know. And two things. You can really recheck the lipids very quickly. 1 month, 2 months. Lifestyle works very quickly.
Uh-huh.
But you usually give it 2 or 3 months to show they can sustain their lifestyle. And then if it worked and it's acceptable, great. And if it didn't work, maybe you give them another couple of months just to prove to them that there's something other than lifestyle going on. And if it didn't work, then you can go to drugs. And the good news then is if you've given a person a reasonable amount of time to try lifestyle, you can then convince them you got some genes at play. You need pharmacologic therapy. If day one you run in and start prescribing a drug, most people are not going to take it or fill it. They're afraid of drugs. So you have to prove lifestyle doesn't work first. Now, again, we're not talking about FH where day one you go on a drug because their magnitude of their lipid abnormalities is so horrific. You need drugs. Same with the Lp(a). If you're in the high risk zone, you got to lower ApoB.
Is it true if the fats start getting inside the artery just a little bit, that's irreversible?
Sure. And it's reversible by lowering ApoB, LDL cholesterol, non-HDL cholesterol. There's two things we do with by removing ApoB particles out of plasma, they can no longer deliver cholesterol to the artery wall. Thus, the plaque you have will stay the same or it will regress. If it stays the same, your immune system builds what's called a thick fibrous cap over the plaque, so it doesn't rupture, setting off a thrombus in your arterial lumen. So that's called stabilizing plaque. And all of the lipid drugs that lower ApoB, LDL cholesterol, do that. And then when you do it very aggressively, and a regression usually starts to occur with LDL cholesterol and ApoB under 50. That's where if you do sequential imaging, CTAs, you will see the plaque is disappearing.
It can disappear, the plaque, after starting pharmacological
Yeah, it can. But listen, the real reason we write drugs is to prevent clinical events, stents, ischemia, unstable angina, myocardial infarction, TIA, strokes. That's really what you want to reduce. I would tell you, I don't care if your plaque is regressing or not, as long as you're not having a heart attack. And the data shows aggressive lowering of the LDL metrics is how you prevent those clinical endpoints of atherosclerotic heart disease. But because we like to see things visually, we'd all be happy that, oh, it's regressing. But you should be more happy that, hey, well, statins, we have 30 years of data now that there's so much less heart attacks and strokes. That's really why we're doing these. But yeah, fine. The regression is likely good. I don't think they've correlated regression that much with MACE, but we like to see things. If a big one is bad, a little one is probably better.
Is there certain arteries where atherosclerosis is built first before others?
Yeah, it doesn't occur all over the body. In the coronary arteries, it's at certain parts where the blood flow is a little more turbulent. It's often present at the ostia of big arteries coming off the aorta. So your peripheral vascular arteries, pretty much in smokers, their arteries start to get small. And in the brain, it's pretty much hypertension, high ApoB driven, but there's a lot of kinks in the arteries in the brain. So blood flow can get turbulent up in the brain. And that's where the particles that you have too many of, they're more likely to invade the artery at those sites of turbulence or damage of the endothelium.
Can we increase our LDL receptors?
Sure. The easiest way to do it, why does a liver produce LDL receptors? Because the liver has a lot of things it does with cholesterol. The liver needs a lot of cholesterol, which is why it's the most cholesterol-rich organ in the body. So the liver, what does it do with cholesterol? One, it makes its own cell membranes. It has to make them right, and they're loaded with cholesterol. Number two, the liver has to make bile acids, because if you weren't making bile acids, you wouldn't be able to digest a lot of the food that you're going to eat today. So, and when cholesterol gets converted to a bile acid, it goes in your biliary system, goes down to the gut where it helps absorb lipids. That's what bile acids do. And here's what else the liver does that most people don't know. We haven't talked much about HDL cholesterol today, but HDL cholesterol is something we measure. That's the mass of cholesterol within your HDL particles. So I always tease people. I say, all right, maybe you have an HDL cholesterol of 45 milligrams per deciliter. Where did your HDLs get all that cholesterol? And people, they can't answer that question. Here's where they get it. 40% of that cholesterol was effluxed from the liver into little small ApoA1, very small HDLs, and the HDLs get bigger. They gather cholesterol. 30% comes from your intestinal enterocytes doing the same thing. When you absorb cholesterol, the enterocytes not only put cholesterol in your chylomicrons, they put it in your HDL particles. 25% of your cholesterol in the HDL comes from HDLs accepting cholesterol from other cells that want to get rid of cholesterol, because too much cellular cholesterol is toxic to cells. It crystallizes and kills the cells. So HDLs, what do they do once they fill up with the cholesterol? They are the deliverers of cholesterol to adrenal cortex, steroidogenic tissue, gonads, steroidogenic tissue, or the main storage organ of cholesterol in the body, which is adipocytes. Adipocytes not only store fatty acids as triglycerides, they are a major store of cholesterol in case the body suddenly needs it for a crisis. So the liver needs to maintain a good pool of cholesterol. If all of a sudden there's less cholesterol in the liver, and the most common cause was because we prescribed the statin or bempedoic acid and inhibited cholesterol synthesis, the liver says, oh my God, don't have enough cholesterol to do all those mechanisms. So the liver says, oh, I have to gather more cholesterol. And there are nuclear transcription factors that sense low cellular cholesterol, and they go in and turn on the genes that produce the things that gather cholesterol. They increase HMG-CoA reductase, so you increase synthesis, and they increase productions of LDL receptors, which grabs ApoB cholesterol-carrying particles and pulls them into the liver. So any drug that depletes the pool of cholesterol in the liver will upregulate LDL receptors, statins, bempedoic acid. But what if your intestine is hypoabsorbing cholesterol? All of a sudden, you're delivering less cholesterol to the liver in the chylomicron. The liver needs cholesterol. It depends on the absorption of cholesterol. The liver will upregulate more LDL receptors to make up for hypoabsorption. So this is why ezetimibe works. You produce more LDL receptors. Bile acid sequestrants, which prevent the reabsorption of bile acids at the ileum. If you don't send bile acids back to the liver uses up cholesterol to make more bile acids. It needs more cholesterol. It upregulates more LDL receptors. That is how bile acid sequestrants lower ApoB. The last thing is what regulates recycling of LDL receptors, PCSK9. PCSK9 enhances the catabolism of LDL receptors, so they don't work as long as they should. Once an LDL receptor pulls in an LDL particle, it should go back to the surface of the liver and grab more LDL particles. But PCSK9 sends the LDL receptors on a catabolic pathway. So all of a sudden, you don't have as many LDL receptors. That is people who have genetically gain of function of PCSK9 is one of the causes of familial hypercholesterolemia. But if we can inhibit PCSK9, LDL receptors recycle more frequently than they would. It sort of increases the half-life or recycle time of LDL receptors, which would lower ApoB. That is how PCSK9 inhibitors work. And that is why PCSK9 inhibitors, which let your LDL receptors work longer, if you co-prescribe a statin or ezetimibe, which depletes the liver of cholesterol, you not only upregulate more LDL receptors, they live longer. Triple therapy. It's all LDL receptors.
Is there any combination of anti-lipid lowering therapy that you don't recommend to put together?
No, it's all the ones we have are safe, and you can use them in any combination you want. So there's no downside. Yeah, you should know that the statins, there's a small risk of glucose going up. There's a small risk of muscle aches. People can't use them. And the other ones are pretty clean. There's not a lot of side effects to warn people about.
And even the statins are with the higher doses, mostly the side effects.
Yes, that's why I prefer the low dose statins with ezetimibe rather than the high dose statins. I think the day where they always recommended high dose statins is going to disappear very quickly. The future guidelines are going to not mandate high intensity statins. There's a place for them. Probably people who have acute coronary syndrome need
For
to be on them
secondary,
for a
right?
while.
For secondary, mostly, the higher doses.
Oh, yeah, secondary prevention. Yeah, I would never use a high, in primary prevention. Most people would not agree to take a high dose statin in primary prevention because they'd go home and read on the internet and it would tell them it's going to destroy them.
And for secondary prevention, if their ApoB is within target on small dose, they don't even need to increase it to higher
Correct.
dose.
It's all ApoB. Yeah. Now, they are the type of people who have had high ApoB for a long time. So you therefore want to really drive their ApoB down. But if you can get there with whatever you're prescribing, you don't have to suddenly turn. They used to think statins had all these pleiotropic magical mystery effects. They don't. They lower ApoB. That's how they work.
So even if someone is using a PCSK9 inhibitor as secondary prevention and the ApoB is within target, you don't have to add anything else?
No, but it's a very aggressive target. Remember, Dayspring would want them under 50 milligrams per deciliter. So as long as you're there, you're fine. Now, because those are the type of people who have had really high ApoB levels. So you might need more than one, but the goal is ApoB. If you can get there standing on your head, then fine. Keep standing on your head.
The HDL cholesterol, how do we know how much of it is the good cholesterol and how much of it is nothing?
Yeah, the problem is you don't. The only thing we measure with HDLs are HDL cholesterol, which has no relationship to what we call HDL functionality. HDLs are a critical lipoprotein. They perform numerous functions, both in the lipid world and beyond the lipid world, because they traffic any number of proteins. Half of them are immunomodulatory proteins that might be good in fighting infection, inflammation, cancer, you name it. So the problem is HDLs can also be dysfunctional, meaning they're not carrying the proper proteins or their surface has the wrong phospholipids on them. So how do I know whether the HDLs in your body are doing all the good things they're supposed to? Maybe they're not doing any of them, or are they doing some bad things? I don't. And there are research little things that are not available in the real world. So we have no way to judge HDL functionality and has no relationship to HDL cholesterol or even HDL particle count. So therefore, I think the only use for HDL cholesterol is calculating non-HDL cholesterol. Otherwise, don't look at it. There is absolutely no goal of therapy. If you have low HDL cholesterol, the odds are high, your ApoB is high. ApoB is the goal of therapy. But if you lower ApoB, it's irrelevant what your HDL cholesterol is.
Is there anything proven to improve HDL functionality?
Probably right now, it would be a guess. It would be lifestyle. Whether any of the drugs we're doing improve it.
There is a lot of cases of Hashimoto's here. They have hyperlipidemia that will be hyperlipidemia. It has no connection.
Yes, but there is complications here because it's an autoimmune disease. So they might have some minor autoimmune vasculitis going on. So I think there are people you want to treat the lipids pretty aggressively if they have autoimmune diseases. Because maybe other than their thyroid gland, maybe they have some minor vasculitis as a co-part of whatever's causing their immune system to do bad things. So look, you could say, and of course, people who don't have Hashimoto's, if their lipids are out of whack, probably need treatment. So, yeah, for both.
Is there any concern about cognitive side effects from PCSK9 inhibitor?
Just the erythema at the injection site. None.
That's it.
None have been seen. You know, I'll give you a theoretical. The monoclonal antibodies of the PCSK9 can't cross the blood-brain barrier, so they can't. There is PCSK9 in the brain, but monoclonal antibodies can't influence that at all. I don't have any information. Can the siRNAs come with GalNAc, so it should only be going into the liver. Can siRNA on those drugs cross the blood-brain barrier? I don't know. With the GalNAc, probably not. That's the liver virtually rapidly clears that. So that's probably I shouldn't have even mentioned it as a potential side effect. But I would love to know if they have any data on siRNA drugs crossing the blood-brain barrier.
siRNA is basically silencing the gene, right?
Yeah, it goes in. Remember, DNA produces messenger RNA, which goes out, and you have the transcription and translation, and you get protein production. If you destroy the RNA, very specific RNA related to a specific protein, the liver will make less of that protein. And if it's a bad protein, that's good.
That gene is only responsible for lipid. Does it have any?
No, that specific RNA, like Inclisiran, is only for the RNA that's involved with the production of LDL receptors, or PCSK9, which affects the LDL receptors. So if you inhibit PCSK9, your LDL receptors live longer. So, but that specific RNA will not affect any other RNA in your body. The RNA that's producing ApoB, the RNA that's producing creatinine or any other molecule in your body, any other protein in your body will not be affected.
When do you strongly suspect familial hypercholesterolemia? Obviously, an LDL above 190.
Yes, in children above 140 is what the standard guidelines say. But look, I think if you have an LDL-C of 170, if I could do serious genomic analysis, I'd find some serious genes out of whack. So, the only reason to call somebody FH is it justifies a third-party payer paying for their PCSK9 inhibitor. If you don't say they have FH, then they don't pay for it.
If the LP is higher, does it necessarily mean that is it more likely that both parents gave it?
No. Most people, believe it or not, have two types of apoprotein in their body. Apoprotein comes in low molecular weight and high molecular weight, big ApoA, little ApoA, and most people produce both. What drives your LP level is how much of the small, low molecular weight do you produce? Because the liver can produce that very quickly. The liver takes a long time to produce the high molecular weight, and that's subject to proteolytic catabolism in the liver. So the more of the small molecular weight you make, the higher your LP level. And that can come from either parent. So it's not necessarily that two parents would make it any worse. One parent can put you in the stratosphere.
And I'm sure there is a lot of genes that we don't even know about, and there is a lot of...
Totally. There are many other genes that can influence apoprotein. There are even genes that you can inherit that, even though your LP is high, it seems to protect you against having events. And some of them have been linked through Mendelian studies. Because this is why not everybody with high LP winds up having a premature heart attack or a stroke. Many do, but some do not. Why? Obviously, there has to be something else protective going on in their body, and that's genes that somehow are ameliorating what apoprotein does. We don't know what they are or how they do it. Wish we could discover it, because then we would have a therapy. But so everything is complicated, and we're right back to the genes being so complicated. Yes, there are other genetic influences. This is why even there are people with high ApoB who sometimes make it to ripe old ages, but they obviously have other protective things at play that most of us do not. But you don't know what those other factors are, so you can't test for them and say, we don't have to worry about your ApoB or your high LP
is a diet that is balanced and contain healthy fats. So healthy seeds, fish, avocados, just normal balanced diet, but with a normal amount of fat. Is that bad for hyperlipidemia?
Oh, it's not bad. I mean, anytime you go on any therapeutic, and that would be lifestyle or drug, lipids you're going to be repeating every year. If they're a little bit out of whack, twice a year. And you would know if something else is going on that's setting off the lipids. But in general, if you're doing a decent lifestyle, it may do nothing to your lipids, but that decent lifestyle is good for you in many other ways, bone, joints, brains, uh, eh,
Should they reduce their
your
healthy fats? What I'm trying to.
Oh, well, most guidelines will tell you yes, healthy fats means avoiding saturated fats
Mm.
and going with the monounsaturated or some of the
Yeah, these ones that
polyunsaturated
I'm
fats.
asking about the monosaturated
Yeah,
and
yeah. So technically, they're a little better. That's what you would get in the Mediterranean type diet. Saturated fat can not in everybody, but in many people, it downregulates LDL receptors, so you can't clear ApoB particles very well, and it also can induce hypersynthesis of cholesterol. So you make more ApoB particles, and your liver downregulates LDL receptors. So saturated fat would be the biggest thing in the diet you can do to help lipids.
is there specific things that they should avoid, like eggs, fats that are not necessarily
No,
saturated
I
and
think
trans fats?
saturated fat number one. But if you are a hyperabsorber of cholesterol, you should limit the amount of cholesterol in your diet. If you are not a hyperabsorber, you can eat all the cholesterol you want, in my mind, because it's not going to be absorbed. But a hyperabsorber, now how do you know that unless you're measuring cytosterol and campesterol in the blood? A small clue to hyperabsorption, and it's weak if you hyperabsorb cholesterol, your intestinal cells, the enterocytes, they overlipidate your HDLs. So increased HDL cholesterol can be a sign of hyperabsorption. So if you see a person with both high ApoB or high LDL cholesterol, but their HDL cholesterol is up, you might at least suspect uh, hyperabsorption, and maybe ezetimibe is the first drug there, or in that person, you tell restrict cholesterol in the
Uh,
diet. Worth a try.
High what percentage do
This
you?
has come out of weak observational data. I never saw a percentage on it. It's just that unexplained high HDL cholesterol. Think of it. If you've done ApoE genotyping on anybody, maybe you did it for investigation of future dementia. You're looking for
Mhm.
ApoE4 alleles. People with ApoE4 alleles hyperabsorb cholesterol. So if you happen to know somebody is an ApoE4, they're a good candidate for ezetimibe.
Do you recommend omega-3? Do
I
you think?
do.
Yeah.
Yeah. For a couple of reasons. Cholesterol is an integral member of every cell membrane in your body, but so are phospholipids. So if you have the right type of phospholipids plus the right amount of cholesterol, you have healthy cell membranes, which then you, in large part, have healthy cells. So phospholipids are a phosphorus head group with two fatty acids. So you like to have some of those fatty acid tails on a phospholipid be omega 3s. They are crucial to cell membrane integrity, and perhaps even more so in the brain, which especially the DHA. The brain is an incredibly DHA rich organ. And DHA makes it, you have to eat DHA, you can't produce it. So it's absorbed as a fatty acid, but it attaches to the phospholipids on chylomicrons or HDLs. And then when they break up, the phospholipids bind to phospholipid transfer protein, which can cross the blood-brain barrier, brings them up there. They can go right in. So I think omega 3s are crucial. I measure omega 3 concentrations in everybody. Very low omega 3 concentrations have been associated with sudden death. So you want to be sure you're not in the very low levels. And certainly, and most of it is observational data, but the having normal or high omega 3 levels, there's less cardiovascular disease, less neurologic disease, and healthier pregnancies has been shown. We know increasing, and from that Reduce It trial, where after they controlled LDL cholesterol with statins and ezetimibe, they gave people EPA, eicosapentaenoic acid, one of the two marine
Omega
fish
3.
oils. Yeah. And that reduced residual risk. But it only worked in people who had very low omega-3 levels to begin with. So again, this is measuring omega-3s are worth it. Most people who are not eating copious amounts of fatty fish are going to tend to be on the low side of omega-3s. And unless you're going to drastically increase that specific type of fish intake, you should take a supplement.
What is the percentage of EPA to DHA that you think
I
is
don't
better?
know. There's all sorts of people have opinions on that. I prefer to take a product that has both. If I prescribe EPA in a high dose for residual risk in people with high triglycerides, like the Reduce It trial, if they have a proclivity to dementia by having E4 alleles or a family history of dementia, I co-prescribe high doses of DHA to them also. I can't cure the heart and kill the brain at the same time. So, but if they didn't have ApoE4, they don't have a terrible family history of dementia, maybe I could go with EPA alone. Some EPA gets converted to DHA, not
Uh,
much.
And what dose, 1 gram or 2 gram
No,
is?
I think if you're using it for reducing residual risk, you have to use 4 grams. Using any omega-3 to reduce extremely high triglycerides, you need 4 grams. If all you're interested in is making your omega-3 index normal, you would start with 1 gram a day, and in 4 months, repeat the level and see has it gone up. If it hasn't, you would escalate the dose. And after a year or so, you would know what dose you need.
Residual.
Remember, omega-3s, they're measuring them in red blood cells. So it's like a glycated hemoglobin. It takes 3 or 4 months to change.
The 4 gram to reduce residual risk means
That's for reducing cardiovascular risk in people who have high triglycerides, insulin resistance. That the Reduce It trial, that's the population they studied. So, in anybody else, I don't know if you didn't have insulin resistance, would the EPA work? Worth a trial. It wouldn't hurt you, but I will not prescribe EPA and not DHA if you have a risk for dementia. You have to have DHA also.
does it lower just a small dose of 1 gram or 2 gram, does it lower the risk of cardiovascular disease and the buildup of
Not that, no, the trials have not shown that. So, observational trials would suggest there is some, but those trials didn't measure baseline omega-3s. So, some people may need higher doses than other people. So, we just don't know. So, I think if you have serious coronary disease, especially if your trigs are above 120, you should use the 4 grams of EPA after you've controlled ApoB and made it perfect, or you do them both at the same time. For everybody else, just make your omega-3 index maybe 8%. If you have proclivity to dementia, you might want a 10% omega-3 index.
is intermittent fasting good for hyperlipidemia?
I lost 70 pounds once doing intermittent fasting, and I stayed on it for almost 4 years, and my lipids did improve drastically. So, in a case of one, yes. I think nowadays, I would think weight loss is much better achieved using GLP-1 receptor agonists. That's the way to treat obesity nowadays. You have to have a very motivated patient to do sustained, severe intermittent fasting. Uh, and I did it and it worked, but there we didn't have the GLP data back then. So nowadays, GLP-1 receptor agonist is the mainstay for weight control. I wouldn't waste my time with intermittent fasting. I mean, if you want to, go ahead, but it's a tough diet.
Yes.
Most people don't stay on it. There's one more thing I want to tell you before I go. We didn't discuss it. It's not a lipid drug, but for anybody with stable chronic coronary artery disease, colchicine is worth a consideration. It's been shown to reduce MACE and residual risk in people who are on aggressive lipid-lowering therapy and blood pressure therapy and dietary therapy, but through obviously anti-inflammatory actions. And it has nothing to do with whether your CRP is high or not, because in their two big outcome studies, they did not measure CRP. So I think if you have stable coronary artery disease, colchicine is worth a try. Now, the trials that prove this, they used a proprietary type of colchicine, 0.5 milligrams. Colchicine has been available forever in a generic fashion at 0.6 milligrams, very cheap, whereas the branded drug is more expensive. So I think the generic is worth a trial, but there are GI side effects with the generic colchicine in X number of people, which do not occur with the 0.5 milligram. If you look at their clinical trials, there was no GI side effects above placebo. So I recommend in people with significant chronic coronary disease, stable, to consider colchicine.
Well, Dr. Thomas Dayspring, has been incredible. I have learned so much today, and I'm sure everyone who's watching is gonna learn so much. This has been incredible recap of the world of
And I would tell
lipidology.
everybody they can follow me on X or Twitter at Dr. Lipid,
I will link that.
at Dr. Lipid. And for medical professionals can link up with me on LinkedIn. I usually don't have lay persons follow me there, but if you're a medical professional, a nutritionist, or a scientist, happy to. And I tweet out a lot of great educational material, which is how
Yes.
you know about me.
And are you writing any books? I know that you have written multiple chapters, but are you writing? I would be the first to buy it.
Uh, I got pulled into Dr. Allo's book. I think it's called Cholesterol Truth or something, like
Yes.
last year. That's the newest book I was part of. Uh, no, in the long-term works, I'm working with a preventive neurologist, writing, at least it's going to be a very long chapter on brain health and lipids. And that's a whole new conversation. Maybe one day you can have me back and we can discuss that.
Yeah, I would love
But
to do so.
that's all. See, I'm too old. I don't like to write anymore. It takes too much time. You got to do all the references. I'd rather just talk lipids and teach that way and draw great diagrams that teach lipids. That's my
Well,
strength.
you're a very good teacher and educator. No wonder you won the Educator Award in
You know,
2023, just
that's pretty. I
recently.
did that at age
Congratulations for that.
70, 78 years old. That's pretty tough to win that award being this old. But it's all because of my social media
Yeah, but well
presence. I
deserved.
still teach as much lipids as anybody, you know?
Yeah,
So
congratulations. Well deserved.
thank you. I'm very proud of that that award because I won it as an old man. And hopefully I can keep going because obviously I love lipids, as you saw just in the last two hours or however long we spoke.
Yes, yes, and I can go on for multiple more hours. Hopefully, we can
Well,
do this again.
sometimes down the road we'll hook up again, I'm sure.
Yes, yes, I hope so. Thank you very much for this opportunity. I'm very proud of this interview, just to be able to
So,
speak to you. Thank you so much.
okay, and I'm honored to be brought to maybe a part of the world where I don't get to be as much. So that's
Yes,
great
your
news.
message has reached us here thousands of kilometers away, and we'll spread it here.
Super. Take care now,
Thank
everybody.
you. Thank you
Bye-bye.
so much, Doctor. Thank you.